But it's true. Okay, Sean Moss. Yeah, all right, everyone. This is Senate Finance, Friday, February 7th. Today, we are taking another bill off of the first. Hopefully, somebody's gonna take it up, which is S31. This is an act relating to a temporary suspension of the ambulance agency provider tax. And Senator Chittenden, do you want to just tell us why you sponsored this, and then we'll have Jen go through it. And maybe Jen, if you could start out telling us what the provider tax is, because or Nolan.
Yeah, well, we usually discuss it together. I'll give you a brief overview.
Okay, that
We want
works.
us back to talk about it.
Whatever you guys have set up. So Tom.
So I'll do a little spiel in about 10 minutes. So I submitted this bill because I heard Ledge Council didn't have enough to do. So I just wanted, give them something to gnaw on for a little bit. That was an attempt at humor. So no, this is a simple little bill that is, I don't know if it's ready prime time, but I think it opens up a broader conversation and it connects two things that I was hearing about. So I have an email in front of me from an EMS organizer out of, I want to say Newport, Sharon Baker, and she just highlighted that since I want to say 2017, 18, for a while, we've been taxing, the state is taxing 3.2% to when an insurance company sends a reimbursement for an ambulatory service. So when an insurance company sends to an EMS provider, which is sometimes a municipality, you can correct me all later on.
Okay. Yeah, I'm not sure that's how it works.
Okay, so that's my understanding is right now there's a tax on EMS reimbursements, but you can correct that. And so that's what is in the email here. And I'm under the impression that's raising about $1.2 million. Okay. And so what the thing I connected it with is that one, EMS providers need more resources. There's always more money needed in a variety of services. But the other thing I've been hearing is from the Vermont League of Cities and Towns, and I saw this as an opportunity to raise some awareness about another topic, which one, I think a lot of you already know this, but when a town or municipality raises a local options tax, so South Burlington has a 1% options tax, South Burlington only gets about 70% of that. So the state keeps about 30% of that. And that goes into a pile of money that is used to pay pilot funds or payment in lieu of taxes for state-owned properties. I'm sure you all know this already. I was told in conversations from the VLCT that that's accumulating in excess of about, or it has had an excess of about $10 million. So the state's taking in more money from communities that pass these taxes in order, in my experience, 8 years on the South Burlington City Council, I always supported local option taxes because we had a lot of people come into our city that need EMS for services. They need to be able to call 911 and get the police and responders to show up. But only property taxes, absent a local option tax, were really footing the bill for those services. So I always supported a local option tax on certain types of sales. So what I thought, and it would be a useful conversation to raise, is one, I know the VLCT is looking at maybe asking to recalibrate that 30% as more and more towns are in fact opting for this local option tax. We can expect additional surpluses in that space. But what I liked about this was knowing that EMS service providers need resources. I thought instead of taxing these reimbursements as I understood them, but Jen's going to correct me in a minute, instead of drawing the money from taking that out of those reimbursements, instead of pulling from this other fund, which in my experience, those local options taxes are really to support EMS service providers. And this would be still state local dollars to draw down the Medicare reimbursement fund. I don't understand a lot of this, and I'm getting a lot of advocacy on both sides. It seems like a worthwhile conversation to be aware of on these pieces, but that's why it's here, and I thought it'd be a worthwhile conversation.
Okay. So 1, 2, how many? Well, got this. Jen's gonna walk through it, and then you give us the numbers.
It was a joke about Ledge Council.
Maybe Jen walks through this and if you want, I could.
Yeah, I think we'll have you explain the provider, and then Chris, do you want to fill us in on anything with?
I was just here to hang out, Madam
Okay,
Chair.
you
Yes,
can
what
hang
is about
out.
the pilot fund? Let me know.
Okay, you can hang out. We'll leave the EMTs to also talk, or the league. So
All right.
Yes.
Good afternoon, Jen Carvey from the Office of Legislative Counsel. So I thought I'd start by showing you the ambulance agency assessment. So this is what assessment is the term the statutes use for the provider tax. So the annual assessment is 3.3% of the ambulance agency's annual net patient revenues for services delivered to patients in Vermont during the most recent annual fiscal period. So net patient revenues is all the amounts that are paid for by all payers, including Medicare, Medicaid, commercial insurance, any other payer for services delivered. And it's really it is based on the reimbursements. It's not any other money that comes in unrelated to the delivery of healthcare services. And this, I believe this was put in place in 2016 and may have begun in 2017. This is one of a number of provider taxes, and the general theory behind provider taxes is that we are allowed under federal law to impose a tax or assessment on various categories of, I think, 19 categories of healthcare providers. We can use the revenue from that as Medicaid match or as the state match for the federal Medicaid program. There are certain parameters. We can't hold anybody harmless. We can't say, give us your tax money, we will give you that tax money back, and then we'll use the rest.
But sometimes that's how it works out.
So yeah, so I mean, it goes into has gone into Medicaid rates. And so it's one of a number of sources that are used to pay Medicaid rates to providers. So this is kind of having the providers help contribute toward our federal drawdown for our Medicaid match so that we have more money to provide in the way of reimbursements. For the last many years, the money has been going, instead of going into the State Healthcare Resources Fund, where provider tax revenue used to go, along with a few other things that created some accounting issues for the state and how we look to the bond agencies. We moved things most things into the general fund. And so at this point, the ambulance agency provider tax and all other provider tax revenues go into the general fund. And we use general fund dollars to match with federal Medicaid for the Medicaid services delivered to Medicaid beneficiaries. So all of that said, Nolan, anything to add or anything to correct?
No, I think you know.
Great. All right. So S31, as introduced, would do a temporary suspension of that ambulance agency provider tax and transfer an equivalent amount from the pilot special fund. So this is for 3 years. Starts out by saying, notwithstanding any provision of that statute we just looked at, the ambulance agency assessment, to the contrary, for fiscal years 26, 27, and 28, the Department of Vermont Health Access shall not assess, and no ambulance agency shall be required to pay the ambulance agency assessment. And subsection B, notwithstanding any provision of 32 VSA 3709, which is the pilot special fund statute, to the contrary, in those same fiscal years, the Commissioner of Finance and Management shall transfer from the pilot special fund to the general fund an amount equal to the amount of revenue generated by the ambulance agency assessment in fiscal year 25, this fiscal year, in order to replace approximately, so sort of an estimate of the amounts that would otherwise have been available in the general fund as a result of the revenue from the ambulance agency provider tax in each of those years. And it took effect on July 1st, 25. So it would be a temporary suspension for 3 years with the money coming from the pilot special fund to backfill what was lost.
And this would be cutting taxes. So I thought that would be positive.
Some of these taxes.
So does it change the amount that the municipality that's participating in the local option tax receives?
Don't believe so. I look over to Chris.
Okay, so they,
I mean, it's not changing anything. It's just changing the use of some of the money that's sitting in the fund. It's not changing any assessment or any disbursement to a municipality.
And I know Joint Fiscal has been working on a report, which I think is about ready on the local option tax fund, which is supposed to go out to communities. It's our one form of revenue sharing. But it has built up a surplus. The
Yeah.
question is this the best way to get it back to communities, or is there something else? We've got communities that have had a significant amount of flood damage and a whole lot of other communities that could. And we had a fund that was set up that never got really capitalized. So, for help towns with damage. So that's a question that's ongoing. This is a proposal to use some of that money in some way. So I've got Ruth and then Chris. Oh, and Martine.
Is this an allowable use for the Medicaid match? I mean, the federal government allows us to assess a tax. Do they allow us to use this other kind of revenue?
I mean,
to
at this
match?
point, all the money goes into the general fund and it is fungible. So I don't, I think Noel and I both looked into this. Neither of us is aware of any restriction on the source of the funds that we use for the match.
Okay,
As long as it's not federal government. Can't use.
Right, you can't match federal money with federal money.
right. Got it.
There you go.
Martine, did you,
No, go ahead, Chris.
might be for you, Jen or you, Tom. Did you say 1.3 million is the amount? That's
Two.
Well,
is
yeah,
the
It's
number.
roughly 1.2-ish.
That's what we generate the ambulance charge.
Correct.
so that 1.2 would stay in your local municipalities. Wouldn't have to remit that.
So it's not only municipalities, there are private nonprofits and I guess some for profit, but it would stay with the EMS service providers.
And then we would backfill that money with a special fund. So that 1.2, 1.3. Okay.
Is anybody gonna have?
Oh, wait, I have Martine.
Okay.
Then-
sorry.
Thank you. My question has been answered. I appreciate that.
How much that special fund that's grown to 10.3? How much is it growing every year right now? Do you know?
An iPhone friend on the side.
Chris Richard, fiscal, on average, we expect that revenues will exceed, the expenditures for, pilots by somewhere in the neighborhood of about 3 million a year moving forward.
3 million?
That's more than
Okay.
Yeah, my colleague Ted Barnett, who, I can throw under the bus since he's snowed in at home, would be more than happy to come in and talk to you all at a future date about an issue brief he just posted on the JFO website, that goes into details about the pilot special fund, and we'll be happy to send a link
And
around.
you can read it. I have a hard copy,
Okay.
which I haven't had a
In
chance
color.
to read
Mhm.
in the traditional green of the month.
Can I ask another question?
Yeah.
Maybe this is for Tom or for Senator Shitten. Is there a reason you did it as a 3-year? Is it just to try it out to see if it's okay?
Try it. I'm floating some balloons. It seems to make sense to me to just consider this revenue source. Just because this is not all our sales tax. These are local options taxes that communities passed to really fund EMS service providers. And so that's why I thought 3 years would be to see if it would be feasible. But I also would hear that the governor's budget does exactly what the chair said, uses the surplus, I think, for some flood recovery services this year. So this might be the broader conversation, expanding the use of these collected revenues to also be to subsidize EMS service providers. But that might be a little broader conversation.
I know part of the Wyman report had to do with transformation of EMS, and I'm wondering if this will help move that forward at all, or maybe. Or
I mean, I think there was a lot of work done last year on EMS that is probably more likely to transform. I'm sure having additional, revenue they can count on can be helpful in accomplishing some of that, but I think that was the more kind of policy oriented part.
I think probably we should all read the report. And then before we decide, just I'd like to hear testimony as to why the ambulance services need this more than others. I know that we also collected from home health agencies, from, I believe, mental
I
health.
think we let the home health one expire.
We'd like the home health one expire.
That's right, a couple of years ago.
Yeah.
How about mental health agencies?
We never done.
I don't
Never
think
did
that's
that.
I don't think that's an allowable category.
Okay,
It's hospitals. Over here,
Hospitals.
hospitals, nursing homes, pharmacy and ambulance.
I didn't tell you that we have hospitals and nursing homes that are also facing financial distress, and I have a feeling if we let one group out of the tax, we will be hearing from other groups. So I think we should hear from all groups. And I don't know, Nolan, can you give us the background on the provider tax, what it is?
Yeah.
Okay. I remember when it had another name.
The provider tax?
It was more in the. I had a
vernacular?
constituent, yeah, the vernacular, I had a constituent who worked for the state who developed it.
Charlotte, did you send me the Zoom?
I did.
Okay, no, I didn't, I haven't had a chance to look. Not there. Can you resend?
I think she sends it in an email, not in the invitation.
Yeah, no, I'm looking at my email and I don't see it. Sometimes it takes forever for it to go from there to
The, I couldn't get on like the expense website this morning and everything was very slow. I don't know what was going on. There's some traditional issues in the health and welfare community with reception, but this morning things seemed to be straightened out by noontime, but this morning things were really down. They said Safari was not responding.
Yeah, no, I have nothing yet. Because I have a presentation from last year that I can show that will
Yeah.
help clarify things. I think it's important to have a conversation about provider taxes to give you the whole picture
I
of it.
can't remember the last time this committee did anything with provider taxes, so.
The last thing you did for the record, Noel, I won't reject this office. The last thing you did for provider taxes was let home health expire.
Yeah, and that was 3-4 years
It was
ago.
probably two.
Yeah, very recently,
Very
it might have been last year.
And it wasn't that we did anything, we just didn't do anything to stop it from expiring.
We had put some language in about it expiring, and then we had kept pushing the sunset
That's right.
away, and then we finally let it happen.
What is home health?
For home health agencies.
Visiting nurses here at Central Florida Home Health.
Or maybe you could send me an invite or something.
They
or,
used to be
here it is.
designated
Yeah, I got it.
agencies, and then there was a court case, and we now have visiting angels. They provide home health services. If your parents are elderly and need someone to help them get up and get dressed, they're part of Choices for Care.
We were taxing them.
Yes,
So they were paying income taxes on it?
No, I'll get into that.
Okay.
I'll get into that.
net patient revenue.
Yeah, we'll get into that. All great questions. All right.
Just get the technology to work.
Okay, we're there. I just have to share my screen now.
I hope you don't mind me bringing a half-baked idea forward. I just thought this would be worthwhile.
We'll take them.
I'm interested.
Maybe we'll burn them.
All right. So this is a presentation from 2 years ago. So the numbers, the revenues have changed, but the concepts are still the same. So they have long been associated with funding state Medicaid programs. In 2022, there was a survey conducted by Kaiser that showed that in 2003, 21 states had at least one provider tax. And in 2023, 49 states and DC had at least one provider tax. The most common type were nursing homes, hospitals, and intermediate care facilities. We actually have a provider tax on intermediate care facilities. We just don't have any more intermediate care facilities.
I was gonna say, why not?
For individuals with developmental disabilities.
Yeah.
Okay,
This is the 19 class that Jen mentioned. The red ones are the ones, home health should be black now, but the reds with the stars are the ones that we have taxes on. I haven't updated this obviously. So now we know it was in 2003, we let it expire because when I did this presentation, home health was still a provider tax. What I will say is that, when a provider, and since I've been here, there's been two classes of providers that have been explored. Governor Shumlin tried to do a provider tax on dental services, and it fell apart mostly because of how complicated it is. In short, and I'm getting ahead of myself, provider taxes are based on net patient revenue. Well, with hospitals and nursing homes, we know what their net patient revenue is. For one, there's not a lot of hospitals and there's not a lot of nursing homes. And two, they have to provide that information to the state as part of the regulatory process. Dentists do not provide documentation to the state, and there's a lot of them. And so when they offered to do the dental services, the dentists were like, no. And they fought it and they didn't want to do it. And every provider tax that has passed has generally been a negotiation between the state and that provider with an upon agreement saying, yes, we want this because it's money that will go that can be matched for Medicaid. So dentists were like, we don't want it. There was no way to regulate. They weren't involved and it fell apart. Now, fast forward to 7, 8 years ago, when we were looking at this, the Ambulance Association was on board. It took some negotiating and folks like Drew did a lot of educating with his members, but eventually it was a provider class that said, yes, we want this because our reimbursements are too low. And this is a way that we can infuse money into the system and then get Medicaid match. In general, our FMAP is, the best way to translate it is that for every $1, I think I said this in my presentation, of general fund state share, we get a $2.43 grace, right? So for every $1 we put into it, we get a $1.43 match. Right. So the idea was get $1 million in general fund increase, and we can put that in and increase the rate by 2.43. Right. So that was kind of that's the history. So we worked with the hospital association to come up with a methodology, a rate that raised the amount that we wanted to. They came up with a system where they worked with the health department to provide their financial information so we knew how much to tax each one. So that is how it came together. So that's the history of how the ambulance provider tax. Now, whether every ambulance company was engaged or involved or with it, there's a whole other story. But ultimately, in the collective, there was an agreement to do this work. Just to give you a sense of what the different provider taxes are, so you can't tax more than 6% of net patient revenue. That is a federal thing. And when I actually started at JFO, the provider tax for hospitals was 5.9%. And then we upped it to 6% at some point. And the biggest, I think the hospital provider tax in 25 or 26 is probably over 200 million at this point. But they're the bulk of the provider taxes. And that's a huge infusion. Nursing homes at that time were about 14.6 million. Home health was about 6 million. Pharmacy was about 800,000 and ambulances are around 1.2. So you get a sense of, and they're different rates, right? So hospitals are 6%. Nursing homes have this sort of per bed tax. And so when that was negotiated, it was like they said, doing net patient revenue doesn't work for us, but if you do it on a per bed basis, it works for us. And so it was calculated in a way that I think it comes out to 4.9% or maybe 6%, but it still fits within it, but that's how it's done. Home health was at 4.25, intermediate care facilities at 5.9. Pharmacy, we do it on a per script basis, but it's still well below the 6%. And ambulances were 3.3%. So that's what the different providers are paying. Provider taxes are, since 2019, provider taxes have gone into the general fund, as Jen mentioned. They used to go into a special fund, the State Healthcare Resources Fund. At that time, we merged a lot of special funds with the general fund because I guess the bonding agencies were like, you don't have a lot of general fund. We have lots of state dollars, but it's in all these little funds. And there was over 200 million alone in the State Healthcare Resources Fund. So there was this effort at the time, it was the Budget Adjustment Act of that year, actually, to sort of put a lot of those special funds into the general fund. So when people say, oh, this dollar from provider tax goes directly in the rates, no, it goes into the water, and then the water is used per match, so it's fungible, but about 1/3 of all the funds used to fund Medicaid. So provider taxes, I'm sorry, I'm just kind of, I haven't been given this presentation in a while. So provider taxes are about 1/3 of the funds that we use to draw a match. I'm trying to remember what I said here. Yeah, so provider taxes, if you look up the one on the right, as the general fund, it's 30% of the general fund. Of 30% of all the funds that we use to draw match on come from provider tax. So it gives you a sense that provider, now hospitals are the bulk of it.
Do you have a sense of how we compare to our peers in other states with regards to provider taxes? Are we taxing more so than our neighbors and peers? About the same?
You know, like I said, the last thing I had looked at when I looked at that was this slide right here, where 49 states and DC had at least one provider tax. 44 of those had hospital provider taxes. And then what rate they're doing it, I couldn't tell you. I would suspect that most are probably at the max, but it's hard to know.
Just 6%, you said.
Yeah. See what else does this presentation have here? This is actually a Jen slide. So I'm going to let Jen explain this one from the sidelines.
All right, sure. So as we talked about, states can use the revenues from the provider tax as part of the state share of Medicaid. There are certain requirements under federal law that provider tax must be broad-based. So if it applies to a particular item, service, or provider, it has to apply across the entire class of them. You can't pick out certain, say, hospitals and say it applies to these hospitals, but not these hospitals. It must be uniformly applied, has to be the same licensing fee or tax rate or per bed licensing fee across the whole class. So again, you can't single out certain hospitals for a higher provider tax than others for a lower rate. And you can't, this is the part I was talking about before, you can't hold providers harmless. You cannot guarantee directly or indirectly that you will return the amount the private providers were taxed to them in rates to make them whole. There's a safe harbor, there's a presumption, and this is why we keep them under at or below 6%. The presumption is that you have met this requirement of not holding a provider harmless if you keep the rate at or below the equivalent of 6% of net patient revenue. If it's more than that, the feds may start to investigate, but they have given a 6% threshold where you're safe.
And we do have at least 2 nursing homes, right, that don't take Medicaid, so they pay. And
They likely pay, but do not
do not.
get Medicaid
We've
rate.
gotten complaints in the past, from them that they pay in, but they don't, because they don't take Medicaid, they don't get any benefits back.
So that was part of the conversation around home health. They're high private pay and even higher Medicare. So, and a lower Medicaid. So the way that they get money back is through their Medicaid caseload, right? So if you're a provider with a low Medicaid caseload, it's going to have an impact. So that was part of the conversation. If you looked at how much they were receiving in total in Medicaid reimbursement versus what they were paying in provider tax, it was about equal. So there was a sense that it didn't really make sense for that particular provider group. So that's why it was determined that it should be. So so people go, well, why did that one go away? That's because it was about break even. And so, and the way that I would frame this conversation is that what this proposes to replace the general fund portion of the ambulance provider tax with the pilot money. So we back billing the general fund in order to back that piece up to help draw match.
But I think before we make a decision as to what to do with that local options, we need, because we've never looked at it, this is relatively new. We need to look at that fund and why is it accumulating? Maybe,
Mm-hmm.
The idea was that it would be redistributed basically to the towns that didn't have an ability to do a local option because they didn't have any number of bars or places people would come shop, or they're most of our small towns. So
Isn't it
to pay payments in lieu of taxes for property that's state owned?
Yes,
Okay,
that's who is receiving it.
right, so but it's,
Almost but many of those towns don't have the ability to do a local option tax because they don't have a downtown retailer.
right, many of them don't, but some of them do, like
Yeah.
you, like Burlington has UVM and they, and
Yes.
other state
So they
facilities.
get
One
payment in lieu.
One compounding factor worth raising on this point exactly is the Wayfair decision. So that is now allowed for the office tax being collected on shipments, Amazon shipments. And so even if you don't have a downtown, there are communities looking at this to help pay for the roads and their EMS service providers.
Yeah.
By collecting on these sales into their district.
And we have looked at that, and it gets into an issue of zip codes. Because some of our towns have multiple zip codes. And I guess technically, if you now deliver food to the town of Berlin, you have to pay the local option tax, even though you might be located in a town that doesn't. So if you have a pizza establishment in Plainfield, and there is one, and you deliver to a town that has, and the question is, how do you know if you're the UPS driver? And normally it would be zip codes. If it's Montpelier, it's a zip code, but Middlesex also has the Montpelier zip code. And Calais, I believe, has at least 4. I know Berlin has at least 4, maybe 5, depending on which.
If I could finish that point that I was making in both my inner VLCT, is they would say just that towns are adopting this more so, which means that's why we're getting more revenue than revenue from pilot because more towns.
Yeah, we do have more. So we will look at that. First, we will look at joint fiscals analysis, since I have a feeling they may have done a lot of the work for us. We will hear from the league. We will hear from the service providers. And then we can decide what, if anything, to do.
I just want to also make the point that I think Nolan or Jen alluded to this, and I just double checked with Drew. There's an EMS study committee that's happening right now that we created last year in a bill about ambulance services. And we also provided a little bit more money in that bill for training. But I think part of their charge, correct me if I'm wrong, is to talk about a more stable funding source. Yes. Yeah, so that's another thing we might want to consider. I mean, I know that this is set up as a temporary thing, so maybe this is a backfill possibility, but they are looking at a bunch of options to how to improve funding for EMS. So I think when's your report due? It's next year.
The first assessment will be back to you in December of next year.
Yeah.
Okay, and we also know that if we do any kind of regional hospitalization or any birthing centers is up, we are going to have a robust transport system.
Yeah, and that was what Senator Gulak was referring to in the whatchamacallit report. What's his name? I was blanking on the name. The Wyman Oliver Wyman report does talk a lot about transport and EMS services too.
So this one is just beginning. And some of it will be down the hall, I'm sure, in health and welfare. Then we will talk to everyone. Any more questions for Nolan, Jen? Let me know if anyone you would like to hear from as we work through this. We'll see where it goes. I think it's safe to say we are not going to leave Well, I don't know. What are we making an interest income? Interest income has suddenly become a big line item. We never used to even report it, they tell us.
We're often getting 5% on our money.
Yeah. We might be making more money if we can get it in the bank. Interest income, if you looked at the economist thing, is become source of revenue for the state. It used to be so minimal, they didn't even give it a line item. But with the new interest rates, 5% on 30 million is not chump change. Was that gonna change too? Okay, we have 10 minutes until Julia is scheduled to be here. But she might be working outside the door. But thank you, Nolan and Jen.
Thank you, Jen.
Some of us are spending all day with them. You're doing more in healthcare. So we can go off live for 10 minutes unless